So attribute workforce crisis to three human resource challenges. Like I said, there was a numeric imbalance from, for example, insufficient production of health workers due to inadequate numbers of medical and nursing schools. The balance that results from education and over specialization. And as a result, in low and middle income countries, we face inadequate numbers of health workers as well as a health workforce without the appropriate competencies required. The third contributing human resource challenge is a geographic imbalance that results from migration, push, and pull factors related to motivation. Pull factors include with working and living conditions, wages, as well as opportunities for promotion and training. And as a result, there is poor retention of health workers in rural or underserved areas, resulting in a maldistribution of health workers. And what's more, we often have health workers that are poorly motivated in these areas. So for the purposes of this talk, when I say motivation, I am referring to a definition by Franco et al., which states that motivation is an individual's degree of will to exert and maintain an effort towards organizational goals. Intrinsic factors relate to a sense of personal accomplishment or recognition, for example, and it factors in motivation, satisfaction, and work commitment. On the other hand, this says that extrinsic factors refer to salary, interpersonal relationships, and working conditions, and that the presence of such factors can prevent dissatisfaction but not motivate. And as a result, Herzberg promoted actions to improve intrinsic factors. Psychologists Ryan and Jesse use similar terminology of intrinsic and extrinsic motivation, but expand upon earlier theories to develop a meta theory and determination theory. They introduce the concepts of autonomous or controlled regulation. So intrinsic motivation, they believe, is completely autonomous or stems from within an individual, whereas extrinsic motivation, they break into four types of motivation, varying in the degree to which they are controlled, or that is stemming from outside of the individual. And I'll come back to this a bit later in the Bihar example. So as I've mentioned, it is motivation of health workers that is the focus of this talk. And as we discussed thus far, improving motivation of health workers is one area of focus to ensure improved health systems and ultimately health outcomes. We will spend some time on what are some of the human resource actions or interventions that can help address motivation. To summarize, health worker motivation results in poor retention and performance of health workers, poor health outcomes. What interventions improve health worker motivation and how to measure motivation in low and middle income countries. So with that, let us explore the first question. To do so, we conducted a study with the aim for what evidence exists about interventions thought to motivate physicians and nurses in low and middle income countries. We searched 5 from 2017 and did a double review to narrow our records to 7 studies. We applied a pre-specified which defined types of participants, as I mentioned, physicians, types of interventions, which I'll touch on in the next slide. Note, we looked at those studies that assessed motivation quantitatively using a psychometric instrument. So here we limited study designs where we could make at least a plausibility level of inference. So that is a study that has some sort of a control. And this was in an effort to look at effectiveness. And again, I'll touch on this a bit more later. We also limit it to those studies that were conducted in low and middle income countries with some additional criteria. There are many interventions thought to affect health worker performance. And as you can see in this WHO framework, they are loosely organized as entry, workforce, or exit strategies. So to add some boundaries to our review, we focused on those interventions at the health workforce stage. And there has been one prior systematic review conducted of the literature prior to 2007 that raised strategies thought to improve motivation. And we found that these 4 interventions overlapped with the findings of that review as well. So the 4 buckets that we included are supervision, compensation, lifelong learning, and system support. Generally, supervision interventions are classified as supportive supervision interventions, or broadly recognition and career development interventions. Compensation interventions are typically split into financial, that is salary support bonuses, or fringe benefits such as transportation, food allowance, and so forth. Lifelong learning interventions are typically done with opportunities for continuing education, such as in-service training, and system support interventions focus on improving the actual infrastructure, supply chain, or personnel availability. The 7 studies that were retained came from 5 countries, and we found that 3 of the studies saw a positive effect, all of which had a supervision component. 3 showed a neutral or no effect of the intervention, and 1 study looking at the intervention saw a negative effect on motivation. It is important to note the potential for bias here, given that there is public always publish negative findings, and that there may be additional studies published in other languages that we didn't capture. So what does that mean? We found that evidence from the last 10 years remains inconclusive about, and especially given that most studies have been done on heterogeneous populations. And know that health workers experience motivation differ likely based on their cadre status. And despite these limitations, though, we did find that all studies showed some positive effect had a supervision component, suggesting that supervision interventions may affect show that there is no conclusive evidence that compensation improves motivation. In fact, in one case, we found that improved financing had a negative effect on motivation. As a reminder, that does not mean that compensation is not important to entry or exit strategies, just that it may not specifically improve motivation of those already employed. Additionally, the compensation intervention was a bit unique in that the additional compensation came from user fees, and the study quantitatively found that this was unmotivating to health workers because they did not like to refuse care. It is important to note that while quantitative studies were the focus, there is an important need for qualitative work to contextualize findings. And as we saw with the compensation intervention, health systems. Okay, so what do we need to measure motivation? So to date, there have been few locally that exist in the South Asia region. Review and a general review of the literature, we propose some principles to inform instrument design to study motivation. We mentioned with the systematic review, instruments should be theory-based. Second, motivation is not visible to and therefore is not directly observable. As such, psychometric tools are used with Likert scale responses. Should be adapted to local contexts, correctly translated, and for reliability prior to implementation. And finally, motivation. Think about if you motivation at work, to admit you are unmotivated. Social desirability bias, or the desire to provide responses in line with expectations, is when measuring motivation. As such, we suggest that where feasible, self-administered questionnaires be used and privacy be ensured for the respondents. So it's useful to consider how this might be applied in a real-world setting. So I'm going to briefly touch on an example from Bihar, India. Bihar is known for having some of the worst health outcomes across the country, as is evident in the neonatal and maternal mortality ratio relative to the country. And these health challenges are further exacerbated by human resources. So numerically, there's only 2 core health workers per population against WHO recommendations for 22.8 health workers. And this is despite many training institutions. And this is also might be due to some migration. So more health workers in these posts are unskilled. This is in part due to the rapid expansion by the government of India that was done in an effort to. In order to staff these facilities, the government shortened and curriculum of the auxiliary nurse midwife program, and programs with only 11 months of training are sometimes the only primary health centers in the 2 most decentralized posts in the Indian health system. This is coupled with the troubling statistic that only 44.5% of nurse midwives truly had a degree higher than secondary school education, indicating that almost half of all practicing health workers are not appropriately certified. Finally, health workers is more than 5 times that of rural density, indicating a strong preference to work in urban settings and the potential for a poorly motivated health workforce in rural settings. So to this end, an intervention was implemented across Bihar, India to provide nurse mentoring. This work was funded by the Bill and Melinda Gates Foundation and implemented in India, and I was part of the evaluating team at Johns Hopkins. The intervention comprised of 2 key stages. The first stage of the intervention was to train master nurse mentors. So in these 2 pictures, you can see how UCSF and Ponto International implemented their simulation training with master nurse mentors. On the left-hand side is the setup where nurses role play different delivery complication scenarios. And on the right-hand side, they're reviewing video footage to critique their own performance. All right. So nurse mentors then primary health centers a month in pairs, where for each week of the month, they visit one facility. At the facility, they provide a core curriculum and also conduct similar simulation trainings with the nurse. And as a result of the training of auxiliary nurse midwives and general nursing staff is done in a low dose, high frequency manner across approximately 8 months. So a cross-sectional study was done with 317. First, 80 facilities were randomly sampled from each group and mentioned with those receiving this intervention of mobile nurse mentoring and a control group where they did not receive the intervention. And then 2 nurses were sampled from each facility. We admitted a tool that we developed called a nurse work assessment tool with 157 intervention nurses and 160 control nurses. We developed some outcomes of interest and multivariable logistic regression was performed to assess the effectiveness. So for this, I'm going to quickly introduce our instrument. We adopted an instrument developed by Dale for the Afghanistan context to the Bihar context for psychometric properties. This tool had 15 items that could be used to rapidly assess nurse motivation in Bihar. So as I introduced the tool was and the items asked seemed based on self-determination theory. There were 5 questions per each motivational outcome, and these outcomes map to self-determination theory. The 4 outcomes in total, motivation, that is when driven by inner self, self-identity. This is to intrinsic motivation. Worth motivation, like a nurse, that is driven by an under the importance of their duty to maintain self-worth, avoid guilt from others. Then there's external motivation or a nurse by expectation of an external. And finally, overall was a summative score. As you can see here, across all nurses, motivation was reported to be quite high with some outliers, with the exception of external motivation. We then fit 3 models iteratively to assess the treatment effect of the intervention of mobile nurse mentoring on the motivational outcomes. So as you can see, the first model looked at the treatment effect alone. Then we adjusted for socio-demographic indicators such as marital status, religion, caste. And then we also added and adjusted for work-related indicators such as degree type, nursing school type, employment contract, and so forth. We found that after adjusting for both socio-demographic and work-related covariates, that nurses in intervention group were 3 times more likely to report high integrated and almost 2 times more likely to report high overall motivation compared to the control group. So in summary, we found receiving intervention had improved motivation, both integrated. In this figure, you can see the top half of the self-determination theory framework, and the bottom half shows how our instrument mapped to the theory. So in self-determination theory, theorists state that autonomy, competency, and relatedness are psychological needs for employees to move left towards more intrinsic motivation. As this is the first study of its kind to look at the effect of a hybrid training mentorship intervention on motivation, we turn to theory to postulate why the effect might have been there on integrated motivation. We hypothesized that an improved sense of self-efficacy, that is, belief in one's ability to succeed or accomplish a task akin to competency, builds intrinsic interest in formerly devalued activities. And in doing so, a nurse may feel more strongly about her identity as a nurse and by definition have higher integrated motivation. There was no effect found on worth and external motivation. This may be because worth motivation was already quite high across, indicating that many nurses are of duty. We also found that external motivation was low across all groups because nurses working in rural settings may be self-selecting, especially given the poor infrastructure and remuneration. It's possible that those working in rural underserved areas are more likely to work due to a sense of duty or work aligns with their identity as a nurse. I'll now just share some closing thoughts. So as you recall, at the beginning of this talk, we posed these two overarching questions in our problem statement. What interventions improve health worker motivation, and how to measure motivation in low and middle income countries? So starting with the first question, what interventions improve health worker motivation? As we've stated, this remains a neglected area of research, given that so few studies quantified the effect of human resource interventions in the past decade. Based on these findings, supervision interventions may have some effect, compensation interventions are neutral or could potentially have a negative effect, and that training and mentorship interventions have some effect. The example from Bihar, India, further shows that mentoring and training nurses like worker motivation. Findings may help and practitioners alike in their efforts to motivate health workers. With regards to our second question, how can we measure motivation in low and middle income countries? The finding from the systematic review showed that there is still a lack of consensus around how to measure motivation. We emphasize that instruments should be theory-based, appropriate, and we present one work motivation assessment, which is informed by self-determination theory and contextualized for the Bihar context. It is the first tool using self-determination theory and the second theory-based tool that we know of that has been developed within India to assess motivation. So I would like to end by posing this question: why should we care about health worker motivation? As we've tried to make for the case in this talk, they are essential to achieving access to quality care, but also they are often the largest share of health budgets. They are often responsible for managing other health resources, and this has especially been demonstrated with the COVID pandemic. And finally, efforts focused on reducing shortages of health workers and improving their retention are short-sighted if they do not also consider the motivation of the health workers retained. The impact of a health worker on quality of care or downstream health outcomes will be achieved if the health workers present are motivated. So I'd like to acknowledge the many people who have supported this work and thank you again, welcoming any questions that you may have.
Awesome, thanks so much, Jaya. Folks, feel free to add questions. You're also welcome to come off mute. This is sort of like a nice, small, intimate setting. Sumantha Rao, did you want to come off mute and ask your question? I can also read it off, if not.
Oh, hi, Dr. Jaya. Thank you very much. Just wanted to know if you have examined other external factors such as social, cultural, educational, or economic factors, or even gender-based biases, because Bihar in specific has got gender-based bias. So were these factors also examined? Were they a factor for motivation levels being improved?
Yeah, thank you for your question. That's really important. So a couple of things. We did look and assess, education status. We didn't do economic assessment, but we did have some proxies such as education and things like that. But what we found with regards to gender, it was difficult to measure quantitatively just because the entire so all of the nurses interviewed were women, but we do know that gender likely does affect motivation. The instruments will likely have to be different for us as opposed to a physician, especially given how gendered the health matters are in India and most other settings. And so I think what we would have seen is if we had done this for physicians as well, it would have looked a little bit different. And we would probably want to also couple this with some qualitative work. So we were constrained by something, we weren't able to do a qualitative study, but I think that would be very interesting to see what are some of the gendered elements. I think what we know about, at least with nurses, is that a lot of them, oftentimes the rural setting is not acceptable to them, largely because of they care a lot about the education of their children, and for them to do the up down from, a lot of them opt to do up down from urban to rural settings in order to facilitate that, and I'm sure that in some effect affects their motivation. So certainly really important factors, just a bit challenging to measure when you have a really homogenous group, but definitely important to consider.
Thanks.
Thanks for that question. Liliana, do you want to come off mute and ask your question? If not, I can also read it out loud.
I'm happy to come off mute. Thank you so much for the talk, for sharing your findings with us. I wanted to ask you about resilience. So at Damagi, we've been thinking about resilience of healthcare workers in low and middle income countries, and it seems to be a related theme to me. Resilience is what we've been kind of defining as the ability to bounce back. If you go through a low point or a difficult situation, you can come out of that and continue working and being engaged. And we believe that resilience skills can help with stress management, with reducing levels of burnout, and that similar to your study, focusing on intrinsic factors can really help to build resilience skills. So I'm curious if you see or saw a relationship between motivation and resilience. And if you also have thoughts on how you would measure resilience, since you spoke about that in the context of motivation. And somewhat relatedly, if you were to do a motivation related study, would you expect there to be an impact on resilience as well, or do you see these as pretty distinct concepts?
Yeah, thanks for the question. I'll admit I'm not an expert on resilience, so I don't know if I can touch on, exactly how it measures resilience, but I can postulate or think about what might be the relationship between motivation and resilience. So I think you kind of hit the nail on the head with regard to intrinsic motivation being a key factor, in my opinion, because if I think about what would give somebody the ability to bounce back or give somebody the ability to maintain a level of motivation or perform given hardships, I think having a high degree of intrinsic motivation would allow somebody to sort of go through hardships more, whereas somebody who might be more externally motivated, in my opinion, that hardship might change their motivation or dramatically quickly affect it in a more serious way. So an example is one thing we did look at with secondary outcomes is the degree to which those that were serving in worse off facilities, how did their motivation compare to those that were serving in better facilities and sort of higher levels? Those that were in worse off facilities had a higher degree of integrated motivation. And so because we didn't do the qualitative study and because we can't say due to them having the higher integrated motivation that they're in the rural worse off area, because they're in the worse off area that they have that we don't know the directionality, I suppose. But my theory is that or often in general that have chosen this profession, knowing what it brings, are more internally or intrinsically motivated. So I wonder, I think what we might differ geographically is my theory. It might differ by those who have opted for different career paths. And so those that might be choosing a private sector career as opposed to a public sector career, who are choosing for contractual versus permanent status. It's some of these things, I guess. And I think in general, the health workforce, my guess would be that they're a largely resilient population because a lot of them have opted to do these careers with such a sense of wanting their community and a sense of identity, as opposed to a sense of doing it because it's the right, it's a duty or something like that, if that makes sense. So hopefully I answered a bit of your question. Happy to chat
Yeah.
more, but it's a very interesting topic.
Thank you. Yeah, thanks so much.
Okay, great. A few more questions from Anjana. Has this work been applied to other contexts, either in India or in other countries?
Yeah, thanks for asking. So I know that there has been some work being done on motivation and instruments being developed. I think for Nigeria, there's been some instruments developed as well as other parts of sub-Saharan Africa. Within South Asia, it's limited, I would say, to Afghanistan, Bihar, maybe Gujarat, I want to say. So it's starting to happen. I think with the COVID pandemic, we're seeing a lot more interest in workforce and people realizing that they truly are such a critical backbone to all health systems. So for example, even with vaccine distribution or distribution of any life-saving interventions, if you don't have A, if you don't have health workers, and B, if you don't have motivated health workers, it doesn't really matter if you have a health facility. It doesn't really matter if you have refrigerators. And so realization starting to happen that we need to focus on them, but also making sure they're equipped and mentally and socially. There is work happening. It's sort of forthcoming. A lot of the work, I will say, is qualitative and is sort of not using a control group to measure effectiveness. And so there is more theory around what could, I would say there's a lot more theory and sort of guesswork around what are these interventions that are improving innovation. You'll see at the end of a lot of papers, they'll do a study, and in the discussion or in the concluding thoughts, they'll say, well, and so this must motivate health workers, but they haven't really assessed motivation. And so guess is we're drawing a lot of assumptions in the literature at the moment in time because we think we know what motivates health workers. But as we saw with compensation, in fact, sometimes increasing things like financing may not be the best approach to motivating health workers. And so I really believe we need to a bit further to look at more on a nuanced way. So yeah, so thanks for that question.
Awesome, thanks. Then the next question in the chat is, does this have any policy implications from your point of view?
It does. I think that, so the government of Bihar, I think, has continued this work with Care India to start, within Bihar at least, and I think in UP now as well. So there is an uptake of this work, not just because of its motivation effects, but also I think other positive effects that they found of the training and such. But I think if I were to draw some additional policy implications from my understanding of the work, I think that we really need to think about how we distribute health workers and how we also oftentimes move them around. So I think one thing that came to mind for me was a lot of times in different states in India, health workers are hired on like a 2-year contractual basis and then shifted to a new setting. Oftentimes they're working outside of settings that are their own settings. And I think some things that we learned are, I think it's more motivating for people to come from their own home, work in their own communities. And so things like that, where obviously there are some communities that may not have health workers that can return, but I think that in a lot of settings, we should try to encourage as much as possible to have longer term so that, for example, I'm thinking back to the education of their children situation, for a lot of nurses, that may be highly motivating to know that they can kind of set roots down in a certain place for multiple years. So I think that there are certainly certain things that could be done. I think also recognition and supportive supervision and really focusing on that are things that I would highlight after knowing that supportive supervision really tends to motivate health workers.
Awesome, thanks. Next question from Juhi is, was there any difference in motivations? Oh, sorry, I just jumped, my bad. What are your thoughts on what can be done to boost nurse motivation, specifically in the government or public sector?
Yeah, thanks. I think I would just emphasize that focusing on supportive supervision, ensuring, so some of the things that some of the examples that we read about were giving grievance platforms. So basically having a mechanism for folks to actually talk about issues that they're encountering in a way that would not face retaliation, and so that they truly feel like they can trust their managers. I think mentorship in general. So in some cases that might look like providing a phone app or providing access to seniors that they could consult with on a more routine basis. So in the MNMT Bihar example, we found that a lot of managers or these master nurse mentors had given their phone numbers, and that primary health center nurses were saying that was really great because they could ask and troubleshoot questions in a more rapid way and without feeling like they were imposing on their superiors. And so I think, or seniors. And so I think that that's the kind of thing that really came out of this, where people really want support. And if we go back to self-determination theory, like I said, there's 3 psychological needs. They say autonomy, relatedness, and competency. And so competency really comes from that training piece of it. Autonomy is also if you give someone training, they might feel more autonomous, but also it comes from feeling like I can take a decision without having to consult everybody on my team. So how can we empower people to make decision making on their own? And finally, relatedness is just the work climate. So we actually did do a work climate assessment as well, as part of our study. And it was really useful to see like what was the actual work environment that they were working in as well. Sorry.
Awesome. Anything else you want to add, Jaya? Or should we move on to the next question?
No, next question.
Okay. Was there any difference in motivation levels between urban and rural contexts within the scope of your study?
Yeah, so our study was limited to rural settings because it was focused on primarily primary health centers and subcenters. So I would also be interested to know this. I think that my guess would be there would be, but I can't guess because I haven't done the study myself. But what we see from other settings, I would guess that there would be, yes.
Great. Next question is from Suparna. In the Bihar program, did you also measure nurse motivation in the sustainability of a program like training of trainers over a longer period of time, say more than 2 years? That's the first question. I'll let you answer that, then I'll ask the next one.
So we did not, just because this was more of a logistics issue that the grant was closing out, and they hired the evaluation team sort of in phase 4 of the project when they were sort of wrapping up the project, which often happens as we know. So it didn't leave much room for a longer term engagement. I think now they are planning to do a repeat. So this was about 2-3 years ago that we did this. So it would be interesting to know whether they're going to reuse these tools and look at it over time. I think that would be interesting. The challenge with doing something like this is that, like I mentioned, nurses move around. And so you can't always find the same nurses to go back at that same exact facility with the same exact environment. And so I think what would be interesting is to see like why. I think you can take these snapshots, but the question is what's changing at the work at the health system to make these differences, I guess, if that makes sense.
Awesome. And then the second part of Suparna's question, did the selection of the appropriate nurses as trainers play a role in how this drove up motivation of the larger group?
That's a really interesting question. I actually don't know the answer to this because we didn't look at, preference for certain types of master mentors. However, this was a question that sort of more theoretically came up in the group because in Bihar, there weren't really sufficient well-equipped nurses to serve as master mentors. So a lot of the master mentors were coming from other states. And so this was a question that was raised. In fact, some of them were coming from Kerala and didn't really know the Bihar context. And so this could go one of 2 different ways, in my opinion. This could come in a way of like, folks see them as more credible because they're coming from another state and maybe they're, seen as an expert, or maybe they're seen as less credible because they don't have the country or the state context in mind. I did go and observe some of the trainings and the rapport seemed really positive and there seemed to be really good interaction between the nurse master mentors and the mentees. So my theory is that it was positive, but I don't know like whether the selection did play a role.
Thanks. Then we have a question from Divya. Any suggestion on how we can motivate higher administration in government hospitals? So this is in the context of our program where we need the involvement of higher authorities on a regular basis.
Yeah, that's great. So I have a lot of thoughts on this. I think that one thing I've seen in Gujarat was, this is just unrelated to motivation, but I noticed this when I was working in that setting, was that a lot of the district health officers and such were given, or oftentimes have masters of public health. And I think that's really motivating for them because a lot of them have this desire to, and this is completely theoretical because I haven't studied this or measured this, but what I observed at least was that I think a lot of them have a desire to give back to their communities. That's why they've chosen this path of going into being a district health officer, but without having the research skills or without sometimes understanding burden of disease or how should we prioritize and sort of strategize, I think they felt somewhat crippled. And so I think a lot of them could speak very clearly about what was the burden of disease in their local area, what was the interventions that they were going to use, and how are they going to prioritize? And a lot of them had even given their personal cell phone numbers to troubleshoot. And so I see actually that, at least from my point of view, that there is a lot of, I mean, it's very variable. So I'm not saying all district health officers are like this, certainly, but some are. And I think my guess is having this Masters of Public Health, and I can't tell whether it's Gujarat requires a Masters of Public Health for them to get that designation, or it's something that they are kind of offered. But I think giving people more credentials, again, like continuing education interventions is a similar thing, because I think then people feel invested in, they feel more excited about their job, and it's a greater part of their identity. So that would be my suggestion. And also I think recognition. So although I did this work on nurses, another team member of mine did look at physicians, and I don't talk about that work as much because I don't know it as well, but what they did find in the qualitative when we were developing the instrument was a lot of physicians mentioned how motivating it was to be given a certificate of being sort of the best physician or best MO in that district, or best MO in the state, and getting that certification or recognition from authority. So I think that would be my other suggestion.
Awesome. And then the next question, was the concept of supportive supervision defined and implemented well? Were the supervisory staff trained adequately?
Is this, sorry, I want to clarify, is this for the Bihar example or is this for the systematic review?
This is the Bihar example, please.
Sorry?
This is for the Bihar example because, you know,
For
like
the Bihar, okay. Mm-hmm.
Yeah, because when in some of the interventions that we have seen, the supervisors did not quite well understand the concept of supportive supervision. So
I see.
how they were policing around and things like that. So, you know, like the alignment to objectives, was it clearly understood where they carrying their subordinates like a team? You know, the elements did it come out well as part of the supervision?
Okay. Yes. So the mentorship intervention, I would consider it of a more of a training, like an in-service training intervention, with a management component. There was also an additional intervention being done at the same time across Bihar with Care India on supportive supervision's own entire intervention. So I think that was the supervision intervention that was being done by Care India was implemented more with managers within a facility. And then the part that I'm talking about with the mentorship model was done by these master nurse mentors, and they were basically providing a couple of different types of supportive supervision in my example, but it was more mentorship. And so I think that was, for example, providing their cell phone numbers. They had basically a way for nurses to contact them if they had any questions. And then they also do an entire module or 2 modules on communication and communicating within your health facility and how to ask for what you need and how to get respect and sort of navigate the tension between a physician and a nurse basically at the health facility, so that it's improving patient care, but also such that nurse to troubleshoot and navigate it autonomously. So the intervention itself, I would consider more like a lifelong learning, continuous education intervention with this element of sort of mentor there, I guess. So I would say it wasn't super well defined, but then the supportive supervision intervention probably was much better defined.
Awesome, great, thanks. I think that's all the questions in the chat. Does anyone, oh, okay, one more question from Akash. Several proponents worry that supervisory visits are not done in a quote unquote scientific manner. Samples are taken, supervisors checking and maintaining the visit data. Do you see scope for supervisory visits to become a bit more organized, such that the data streams can be archived properly and used for improving administrative data quality?
To be honest with you, I'm not sure what setting. I think it would depend on what setting, and I think that it would just depend. To be honest with you, I'm not quite sure. Does somebody want to come online and sort of specify what they mean by this? Akash?
Yeah, hi, I'll try to. So in some of the policy conversations, I've heard very strong support for increasing sort of data capture activities as part of these supervisory visits. This is, I'm saying, in the context of ASHA workers and ASHA facilitators, more specifically, as a way to sort of do some data quality improvement. And all of this is in quotes. I am not too sure about what works and whether this is additional work, but I'm running into a lot of people who are like, who tell me that, you know, we should have a more scientific sample derived for these supervisory visits. As of now, we don't know how the visits are happening, and if only a scientific sample-based visits are happening, then that data can become a stream in itself of keeping track of whether the incoming data quality is good or reliable or not.
And this is to monitor, you're saying, like ASHA activities and whether or not they're being
This
connected?
is to, yeah.
Okay. Yeah, very important. This is, I know more about other work that I've done, but I think that my thinking around this is that certainly the routine data that we're collecting from community health worker activities like ASHA activities and such are probably not the most scientific. I've worked on some monitoring tools for an NGO that similarly has community health workers, and I've seen data quality issues. I think that I'm not exactly sure the best way that we could go about whether it would be like a survey that needs to be done. I'm thinking of like household surveys where we do coverage surveys, you know, whether similar would need to be developed for community health workers. But so something Seva Mandir, the NGO that I worked for, did was they did camera monitoring, which was done in partnership with JPAL. And so I think there are some innovative ways to do supervision and monitoring that may need to be explored if it's more for an immediate action type of need. So for example, if we're not trying to quantify more broadly, are ASHAs performing well, in which case maybe that requires like a snapshot survey. But if instead you're trying to take immediate action on trying to capture the worst 10%, you know, ASHAs that we need to then either replace or whether we need to, you know, take some action, then I think we need something that's a bit more real time monitoring such that actions can be taken in a more quick and deliberate way. So I think it would depend on the aim of why are we doing this surveying and supervision. And so yeah, so that's my take on that, I guess.
Great. We still have about like 9 minutes left. Does anyone else have any other questions?
Yeah, I have another question, please.
Sure.
I might have missed it, Dr. Jaya, in your presentation, but In terms of any indicators for quality of service, um, have you identified any broad framework of indicators that can be tracked where motivation levels are different?
When you say quality of service, sorry, can you clarify that?
See, because like at the end of the day, the A&Ms are involved in service delivery.
Yeah.
So there are certain metrics available for quality of service.
Oh, I see. Okay. Yeah. You're saying, did we
So
see?
does
Go ahead.
so what sort of indicators do you look for? You know, like what sort of changes do you look for in terms of any specific indicators, like quality of service indicators that you look for where
Sure.
motivation
Yeah.
have changed?
Yep. I hear what you're saying. So exactly. So basically, if you think of motivation again in that framework as sort of in the middle, and you have the stuff that comes before it, which is what do we do? What can we use to motivate health workers? But what you're sort of saying is once they're motivated, how can we see if that does have the health systems performance improvements and health outcome performance improvements that we're anticipating?
Absolutely.
Right. Yeah. So this study was done in conjunction with quality of care assessments that were done, like direct observation of delivery, and some others as well. Like they did OSCEs to see, were their skills actually improved and things like that. The challenge, and we thought about trying to link the two to see does motivation improve. The challenge is that a lot of the activities that are done at a health system are done in a team format. So, for example, a delivery isn't done by just one nurse. And so, oftentimes, how would we then link that individual nurse's motivation to an improved health outcome if it was a team-based activity? And so that's where we really struggled with, especially with delivery, and because a lot of the mentorship and training was done around deliveries. Those were really the activities that we looked at the quality of. But that's not to say that it doesn't have an effect on performance. And I think that is something that needs to be done, is looking at whether it's using clinical vignettes or something. Maybe there's another way to connect it to more of an individual level, looking at quality of care, performance, and does motivation affect it. So I think that would be certainly the next step in something like this, is for us to see where nurses more motivated, and then look at did level of motivation affect performance. So hopefully that answers the question, but that's a really important one, because we don't want to stop at just a motivated nurse or a doctor. But the other thing to add to that, there's a really interesting caveat here that if you increase the motivation of a nurse, it doesn't directly translate to increased health systems performance. And that's because there's so many structural barriers to performance. So for example, adequate hygiene, cleanliness, other utilization issues, such as our mothers even getting to the facility. And so it actually, some literature has said that if you actually motivate nurses, but then don't adequately give them or provide them the resources to actually perform their job, then it can actually be very unmotivating, because they know how they could have that life-saving intervention be used. They know how to save life, and actually have the resources to do so. And so it's extremely important that alongside this, that we're also building infrastructure, improving supply chain, and things.
In fact, I had a very specific objective in asking you this question, because if the government were to think of, let us say, a scheme of incentivization, financial incentivization, is there a possibility that we could link these indicators and sort of encourage the government to think of a policy of financial incentivization? That was the objective.
So based on performance, you're saying?
Yes.
Right. Pay for performance is an interesting intervention, and it is done in some places. I think there's a bit of disagreement, as we know, about pay for performance, and I think that one of the challenges is that it might distort activities. So for example, if you tie payment of performance to, let's say, how much vaccination someone's doing, but not to antenatal care visits, then are they going to now emphasize more vaccinations at that facility? So you kind of have to weigh pay for performance can be tricky because it has to be done really well if it's done, I think, in my opinion, and it can also be distortive. But beyond that, like I said, if the nurses don't actually have the ability to execute, let's say they're getting paid more for vaccinations, but then they're not getting the supply of vaccinations, then that can actually be really concerning because it's out of their control sometimes whether the supply chain is there. So we want to be careful about linking, I guess, financial remuneration to things that are outside of the control of a nurse and make her feel, worse about it, I guess. Sorry.
Great, thanks. Akash, did you want to ask a question with the text that you've copied?
No, that was just a reference for Sumantra. This is about the Janani Suraksha Yojana, where we did run into some problems in terms of perversely incentivizing C-section deliveries vis-a-vis the other kind. So I was just seconding Jaya's response to Sumantra.
Yeah.
Thank you.
Great, thanks. Okay, we got about 2 minutes left. Any final questions for Jaya before we close?
I was tempted to ask this question right from the beginning, but did we compare the motivation levels in the private sector, because India is a private sector driven health system with 70% private care. So how is a peer level motivation in the private healthcare system as compared to an A&M, for instance?
100%. Yeah, this is, I think, also a really important area that needs to be looked at. Hasn't been done yet, but very important. I would guess one of two things. One is probably that the health workers that are there have different motivators to begin with. So I would guess that they may be more, this is a completely guessing, but I would guess they're more externally motivated. They may be drawn to that job because it has greater financial remuneration. But the other thing I would guess is that a lot of them are also listed in public sector facilities, and there's probably this like duplication where they're on both rosters. And so it would be interesting I think that would be a very interesting area of study, actually, to see how our private physicians or nurses different to public sector ones. That answers your question, but there is other types of work that could be done to look at choice. So like I mentioned, there's that exit, entry, and workforce levels of strategies. And I think one of them is entry. And entry is sort of looking at how do you recruit people to public sector maybe, or encourage people or incentivize people to join certain types of work. And obviously we have a great need for public sector work, especially in rural areas. And so some of the work around that could be done as a discrete choice experiment, where you essentially give a list of choices and you create a false dichotomy. So you say to somebody, if the job description is exactly the same, but let's say one job description provides greater financial compensation and the other job description provides greater recognition or opportunities for promotion or education, which one do folks choose between the two job descriptions theoretically? And that can be an interesting way to look at how are people making this choice to begin with. So again, really interesting question. We don't have the answer to that, but I think it would be really interesting to see.
Great, thanks so much, Jaya. And thanks everyone for coming and for your really thoughtful and engaging questions. There'll be more coming soon. So follow Nor Health on all the various social media channels, and you'll hear more when we have more sessions soon. But thanks so much, everyone. Have a great day.